Okay, right at 6 on the button, getting started here. 6 o'clock means it's time to talk brains. I'm Dr. Nathan Keiser. You can see down in the corner there, we kind of did a little software upgrade. So now you just know who I am. We're going to let everybody trickle in here for a moment, make sure the stream's all working. Again, this is still kind of new to us, so we're figuring it out. And then we are going to have our guest join us in just a moment, who is Dr. Kipros of the Keiser Clinic. And she's going to join me. We're going to talk about brains. We got a little agenda to do today. We've got Dr. Wife Keiser here also. She's going to take down some questions, and then she's going to put them up here for me so I can see them in a Google document, because that's the kind of technology we are up to over here. And, oh, there's Dr. Kipros. Let me bring her in and see if we can pull this all together. What do you think? All right. On your mark, get set. Oh, okay. Let's split the screen here. Dr. Kipros, can you hear me?
I can hear you.
Now, let me make sure. I might have muted you. So we're going to figure this out. Let me pull down this stream so I don't loop it real quick. Pull this one down. And then we're going to go audio. Unmuted. Go ahead and say a few things for the camera there.
Can you hear me?
I got you.
Okay.
Good over there. All right. Look at us go. So world, this is Dr. Erin Kipros. She works with us here at the Keiser Clinic. Amazing doctor from the great country of Canada. So Canada has lent us one of their very best. We're not giving her back. So there we have it. So today, what do you think? We should talk about brains and stuff?
Let's do it.
All right, cool. We're going to go just another minute so we can let people join us. And then we've got kind of a little bit of an agenda to go through today. We've got slides. We've got some Q&A. Are you excited for that, Dr. Kipros?
Oh, that's the most exciting.
I'm glad to hear that. I can see Dr. Claire Keiser, aka Dr. Wife, is already typing away.
Someone asked, who's your favorite client?
Oh, who's their favorite client? Do we have someone in the chat? Why can I not see the chat again? I gotta solve this.
I'll add that to the questions.
Why can't I see the chat? Let me take one moment, see if I can figure that out real quick on the fly.
Do you see that on the right side of the screen? The bottom button, it says chat.
Ooh. There it is.
What would we do without you?
We got it. Let's go. Let's overlay. Nope, we're not doing that. Okay. Oh, I know who that is. Look who's here. Fellow who tries to break my hands every time I see him. All right. Okay, so I think we should get started. Dr. Kipros, I'm going to pull up a little PowerPoint here. I thought we would start with, actually, we'll start with this window here. Let me pull it up. It takes just a moment. Share. Okay.
Like 10 seconds.
So I don't know. I think you guys can see this now. Let me see if I can stack us over here. Okay. So this is just an article that was posted on Medscape, and it was from an interview that was done in October of 2023 with a cardiologist, and it's not meant to be as any kind of like a hit piece, or we're not talking mean about anybody, but in this article, they're talking about postural orthostatic tachycardia syndrome. And they're saying there's this little section here that's entitled, as you can maybe see, no tilt table required. You remember seeing this, Dr. Kipros?
I sure do.
So she does a good job. She describes like what it is. Hey, somebody stands up, usually 30-point heart rate rise from when they're laying down. Great, usually associated with symptoms like lightheaded, dizziness, cognitive difficulties, brain fog. Awesome. So the diagnosis can be made by tilt table testing, but it can also be made in the office with simple orthostats. And orthostats is just like testing done, changing from the supine to a standing, or laying down to a standing position. And in this case, she makes the argument. She says, I have people lie down for 3 to 5 minutes. Cool. And at the end of that period, they measure their heart rate and blood pressure. And then they stand them up for 3 to 5 minutes. And then again, they take the heart rate and blood pressure and look at the differences. And they're just looking for that. They're looking for that heart rate rise by 30 points. And she says that's POTS. So very objective criteria. And then kind of basically goes on to say, where am I at here? That because of this, the symptoms and the fact that the heart rate changes is kind of like all the criteria that they go through. And this was given to me. I didn't hunt this down. This was given by a patient. And they were kind of curious about it because in our office, we actually do like the opposite. We do like a lot of testing. And the reason this was important is because it's kind of like, it's giving, I would say, giving permission for, once we've, done the 3 to 6 to 9 to 12 month wait list, we go to the cardiologist and we do a sit to stand. That is a great screen, right? It's a great screening tool to be able to see if, yes, in fact, we are having changes in the heart rate. But I think what the problem we see with this is it's kind of like, all right, so we're ending the investigation there. But what really needs to happen is this needs to be the entry point for when we actually begin the investigation. Does that make sense? Dr. Kipros, what do you think about that?
I agree. I think a lot of when people that we see are at exactly the point that you're describing is they've done this, they've had this initial screening test, and then they're frustrated because they don't know what to do from there.
Yeah. So, and I think that that's a good option because really what you're saying is at that point, like, if we're going to make an intervention, the only option we then have is basically like to try to treat heart rate. And while I think that can provide some relief for people, I think there's a huge number of people that what they're trading off in relief, they're giving up in function. And I think that like that is kind of the crux of what we're talking about today. So what I wanted to talk about was maybe how we start to work through that. And then I'm even going to give a couple ideas on things that are screening tools that people can use to kind of get you to a place of being able to then seek out what would be next, if that makes sense. How's that sound?
Sounds good.
All right, let's give it a run. So let's see. I got a little teeny tiny screen over there. Let's see if I can open this up. Oh, it does help. Look at us go. I wonder if I can just make that a full screen. All right. Okay, so there's our fancy starting title. There we go. So we kind of are, our perspective is that we need to get to this point where in these cases, but not just in cases when we think about POTS, but these can also be in traumatic brain injury, concussion, a lot of neurological conditions that we see, you can take it to the bank, they're going to have alterations in their heart rate. But the thing we have to remember is the heart rate component of it is, unless there is a cardiac problem, unless we have something blocking a blood vessel, heart rate is not going to be the driver of most of the symptoms that we see, especially in people that we kind of think of as having POTS or having dysautonomia. It's one of the symptoms. It's just an easy one to measure. And I think that fact is kind of the thing that gets us kind of so hyper focused on this heart rate idea that we kind of miss the bigger picture. So what we want to do is take that focus from heart rate, and we want to expand it out, and we actually want to start by thinking about it just simple terms of blood flow, because that's really what heart rate is doing, is managing blood flow. So if we think about the conversation we just had where we just do a simple lay down, stand up test, we may catch changes in some heart rate, and we may catch some changes in blood pressure, although it's hard if we're just taking a couple reads, because it can be dynamic. So a different way to look at it would be in a graph like this. So I'm just going to walk everybody else through it. This is kind of the way we look at it all. This is actually taken from a paper written by Peter Novak, who's a brilliant neurologist, but he's organized it so well here that I used it in a previous lecture. So that's why we're using it here today. But we've got just files and files of cases that look just like this. But the thing to notice is, like, what happens if you get a situation like this one, where I'm going to walk you through it, everybody. So we've got heart rate up here at the top in this red band. The blood pressure is this black kind of staticky waveform. And then this blue one is cerebral blood flow velocity. So it's kind of like blood pressure, but the way you think about it is going into your brain. Very simple. And then this gray part of the test is when someone's laying down. The white part right here is a tilt examination. So this is when they're tilted up to 70 degrees. And then they're brought back down to laying down at the end. So the thing that's really important here is you can see this heart rate number is starting off at about 83, but it doesn't ever, like 110, for example, would be 30 points above that. So we would expect if somebody's got POTS, then that heart rate during the tilt should crank out and go at least above 110, right? But in this case, you see it doesn't. But all the symptoms are the same symptoms somebody has with POTS. So what do you do in that case? You can imagine, whoop, got my pen. Oh, okay. So you can imagine if we just took this same person, we stood them up and we saw that heart rate, but we know they're getting dizzy and they're telling you, like, I'm on this tilt table and I feel terrible. Like, I'm getting dizzy, nauseous, and lightheaded. But you're looking at that heart rate and you're looking at the blood pressure staying pretty stable going all the way across. If you look at this top range versus the bottom range, there's no difference. Like, if you were to draw this out, there's no real difference from laying down to tilt, right? Okay. So in this case, what would you do? So Dr. Kipros, we see these, I mean, it's not hyperbole to say every day, right? Mm-hmm. So if we're looking at these cases, how many times do we hear of kind of this sit to stand or lay down to stand test, and people, what are people getting as feedback when we're seeing these kinds of things?
When we see that people don't fit the traditional criteria, a lot of the times they're just given no option. It's like, oh, you don't fit this typical criteria that we see, so it's on to the next thing, and we don't really have anything to give you.
Yeah, and that's like best case. So that's like the polite Canadian version of that. And the worst case was what we usually hear, where people are just kind of like, maybe you need to see a counselor. Maybe it's in your head. Maybe you're anxious is usually the quickest diagnosis that a lot of them are given. But in this one, if we take the same idea here, where we're looking at the blood pressure and kind of looking at what that number looks like when they're supine versus tilted. And then we go down here and look at the cerebral blood flow velocity. What you'll see is on the lower end, we've got some stability, but you can see on this upper end, you can see it starting to teeter off here toward the end of the test. So right at this point here, you can see where we're starting to lose some of that blood flow. So we're starting to see a drop in the blood flow that's coming to the head, and you can actually start to see this little bit of an arc of elevation of the blood pressure trying to compensate for it. And another way you can look at that is this other graph here, where the kind of the lighter line is when they're laying down, and the darker line is when they're on a tilt, and you can see the blood flow velocity is dropping. So this is just like one illustration, I guess, of one of the ways that we can see where while heart rate is a useful thing to look at for some cases, when we're thinking about most of the symptoms of dysautonomia, it's just insufficient. It doesn't tell enough of the story to teach you or to inform you on what you should do next to try to help. Is that a good way to put it?
Yeah.
Cool. All right, well, let's go ahead and let's go to, so does anybody have any questions on that just in the chat before I move on? Because I'm going to show you another one. So JP's 3 said, could something like the Lumia wearable tracker help identify these in patients without access to sophisticated autonomic labs? This is from X. That's probably why you don't have it on that stream. So that's a good question. So the Lumia tracker, I don't know how many people in the chat are familiar with that one. One second. So what this does is it's kind of like, it almost looks, maybe you could say like a hearing aid. And what it does is it just uses almost like a plethysmographer, like the thing you'd look at like for a pulse ox on your finger, but it does it on your ear. And it can basically it gives you an index of anticipated blood flow through the ear. And they have, like the group that put that together, it's kind of a newer product. But the group that put that together basically uses that as a way to track blood flow. And I think on one hand, I think it gives you a good rough estimate on what that might look like as far as flow to the head, which I think is cool. And on the other hand, though, we're also seeing it being conveyed as like an external source. So we'll see these cases where, okay, so let me back up. I wonder if I could draw it. Well, we're going to see him talk about it. So on the way up the neck, you've got a carotid that's coming up, and that carotid is going to branch into the internal and the external carotid. So the internal carotid ultimately becomes the middle cerebral artery going into your brain, and that branches off in the anterior cerebral artery, and we kind of get like this nice tree of blood that goes into your head. And then the external goes basically to everything outside of your skull. So everything kind of like in the muscles and skin and tissue outside of your skull. So the external one and the internal one, while they both share a common entity, they branch off and do a little bit different functions when we think about it in the head. So one of the downsides is that we're looking at external flow, which for some people will be relative, right? And you can see the same thing by just palpating temporal artery pulses. People that have been in the office see me do this quite a bit. But we're looking at external flow as a starting place. So with the Lumia, we are limited in that sense, but it can tell us if we're having problems that are kind of like encompassing the whole head. And for some people, that's pretty useful, especially if you wear one and then you can start to notice that there's differences with postural components. That's a pretty useful tool, probably a step up from using a heart rate wearable. The other thing, and I haven't used it a ton, so I am kind of like giving that caveat, but also it gives you an index score, kind of like HRV. So it's giving like a proxy correlate score. So it's its own score. What we'd like to do is see them correlate it to either a pressure-based score or with an ultrasound. But it's tricky because it's hard to take that pressure from kind of the capillaries in your ear. But I do think that with nothing else, that's a super useful tool because over time it can kind of tell you what your exposures are. And we will see that those are going to be particularly useful, especially in people that have changes in vascularity in their neck. So if I'm someone that when I'm turning my head, I'm changing the internal jugular vein or the carotid, those are going to be sensitive to issues like that probably pretty consistently. So really good question. I appreciate you throwing that one out there. Anything to add, Dr. Kipro? Sorry, I kind of took that one and ran.
No, that was great.
Okay, cool. Okay, thanks, JPs. Let's go to this next one here. So this is kind of like, we're kind of in the same boat. And then, but here we're adding another variable to the test. So again, we're still in tilt test, but instead of just having, we've got our heart rate in red. We'll start over here on the left with the control one. And then we've got our blood pressure in black, and we're kind of familiar with that now. And then we've got our cerebral blood flow down here in blue. And that's going to be kind of calibrated to this green line. And the green line is the end tidal carbon dioxide measurement. So Dr. Kibros, why don't you run everybody through kind of what that's measuring?
So the end tidal carbon dioxide measurement is our way of proxy measuring the amount of carbon dioxide that's in the blood. And we'll do it in this measurement. You're doing it by how much carbon dioxide you're breathing out. So we know that that amount of carbon dioxide in the blood will alter the pH within the system. And that's detected by different receptors telling the vessels in, specifically if we're talking about our brain, whether they need to be dilated, allowing more blood to come in, or constricted, making it more difficult for blood to flow in. Exactly right.
So it's kind of like in your brain, we have these vascular reflexes. Like you don't have to think about it; they just happen. But there's this weird, it's a wild superimposition where the vessels both respond to the amount of pressure and to this vasoreactivity to CO2. So anytime we're measuring this in the brain, we really have to also compare it to the CO2 to know, is this because we're responding to the pH in the blood, or is it because we're responding to the pressure in the artery? And so overlaying those two things is you kind of have to do it that way. And you can see these little pink and yellow lines are how you would correct for changes in EtCO2 causing changes in blood flow. So the easy thing, like you can change blood flow really easily by having someone hyperventilate, breathe really fast and shallow. Because when they do that, they start blowing off more carbon dioxide. So the amount of CO2 in their blood is going to go down, which is going to cause vasospasm, which is going to tend to decrease the amount of blood in someone's brain. So the same way if someone's on a tilt test and they're kind of freaking out a little bit, sometimes that happens. People are worried they're going to pass out. You see some crazy TikTok video of someone not having a good experience and people get scared. We, of course, run a wonderful, very easygoing tilt test. It's basically like going to the spa. You'll really enjoy it. Anyway, but when you look at these on the control, you should see kind of flat lines all the way across, right? So you got red line looks pretty flat into the tilt area. The green line looks pretty flat going into the tilt area. The black and the blue, those are flat. That's how the typical human should work. Like when you lay down and then you stand up, ideally, we don't do less things standing up. So we have to be able to get the same amount of blood in our head when we're standing as we do when we're laying down. That's just kind of table stakes. That's par for the course, right? So you can see we're gonna slip all the way over to the right side and look at this person that was diagnosed with POTS. With this POTS case, one of the things we want to pay attention to is, yes, we give it a name of POTS, but there's way more nuance. So we see this accelerating heart rate. One of the things that I think is worth noting is that it's starting at around a 90, which is not low. So we're already starting at a base or higher type blood pressure, or excuse me, heart rate. And then that heart rate, you can see it drifting up over the test. It didn't do this thing where it just screams up and then holds, right? How do I go back? It drifts up gently. We can see that we get this compression of the blood pressure, which is what you should expect when the arteries are constricting. But then you see this CO2 level is starting to drop, and you go, well, that's going to lead to some vasoconstriction in the brain. And then you're going to see that the cerebral blood flow velocity is dropping kind of at the same pace. So when you correct it, that pink line you see stays pretty stable going across. So it's not necessarily as a consequence of just the breathing. The whole system is decompensating. We're losing this blood flow relative to this kind of change in CO2 levels. And to save the day, that heart rate goes up. And that's going to be different than if we saw this same pattern where the heart rate's going up, but this ETO2 stays stable, and let's say the cerebral blood flow goes down, or let's say the cerebral blood flow is able to stabilize. So they're all grades of the same thing. So like if I can use just a heart rate acceleration, and that allows me to be able to sustain the blood flow to my brain, I'm probably going to have a different symptom load than if that blood flow level drops. And hopefully that makes sense to everybody. So even though they all kind of fit in this category of POTS, the way we're going to explore the treatment of that is going to depend on how these factors all work together. And then kind of the last piece, and then ask questions about that if we need to, but the last little chunk is if we look at this one, which is hypocapnic cerebral hypoperfusion. And you say that 10 times fast, please. But what it means is the hypocapnia is this CO2 level dropping, and that could be because someone's hyperventilating. Hyperventilating tends to come in two forms usually. Number one would be tachypnea, which is the fancy word for like fast breathing. Okay, fast and shallow. The other way it can happen is because we have what's called hyperpnea, which is like the really big deep breaths that are really exaggerated. For those of you that have ever done like a deep breathing practice, maybe you've done some paced breathing or some meditation where they tell you to take deep breaths, but then you also kind of start to feel a little bit loopy and dizzy. That would kind of be hyperventilation, but hyperpnea, where you're breathing really big. Okay, either way, that's kind of an aside. In this one, we can see where this number is going down, and that's drawing down this cerebral blood flow, which means we have a higher likelihood of creating problems, having symptoms, creating ischemia in the brain. But we actually see a little bit of an increase in blood pressure, but almost no change in the heart rate. So if you were to just block off this green line and the blue line, right, we pretend those aren't there, like we were just doing a lay down and stand up test, right? If you were to just look at this, you'd be like, this person's doing great. And then you would, we send you home, off you go. Great knowing you. Maybe we can try to do some things to try to help with your symptom management, which is just unfortunate because like this is an opportunity to solve the problem right there. So that's kind of what we wanted to get across, I think, in a large degree, is just this idea that with more information, you can learn things, and it allows you to just make a better decision. And in the way we talk about this in the office is each person may have the capacity to compensate differently based on the type of pathology they have, but also how long they've had it and how long they've been making that compensation. So over time, we can also see people that may have started off in one type of presentation, one type of pathology, degrades further down the line, and it turns into additional problems down the line. So looks like we got a couple of questions that came in. I'm just going to quick look at them here. And then feel free I can stop here for a minute and we can just kind of talk about this because I think it's really useful. And just to your heart's content. And then once we're done with that, then we can kind of move on to the next part. Anything to add, Dr. Kipros, while I look at this? Take it away.
No, I think you did a really great job of explaining that. And I think it ties back to what we were talking about at the beginning about being frustrated with getting the result of a screening test like that and then attempting to treat the compensation instead of attempting to treat the underlying cause that's causing the body to react in that way.
Yeah, I think that's reasonable. Nicholas Lyman, I'm not sure if you're trying to stay to the top of the chat here. There we go. So we're going to bring his up first. Now, we have to kind of make this little, see this thing I did where I could just pull that baby right up there? Isn't that slick? Okay, so disclaimer, we're not giving medical advice. That's not part of the show today. In order to do that, I got to see you as a patient in person because I'm not very good at seeing people remotely, number one. Number two, there are legal constraints to those things. So if you do have a question, it's like a personal question. I can't like give you an advice on that, but we can talk about things in generalities. Also keep in mind, my license is as a chiropractor. I'm a chiropractic neurologist. So I have a chiropractic license and we practice clinical neurology, which is wonderful. But it means that if someone has given you like, hey, you should, like a physician says, I would like to prescribe you these medications, you shouldn't necessarily just ask internet doctor to override those recommendations. It does mean that you may be able to go back to them with a different set of questions around like, hey, what do you think about some of these other ideas? And you can kind of have that conversation with them, but we don't want to override, especially someone who has had a chance to look at you and evaluate you and run some tests, things like that. But with all of that said, the question is, many specialists recommend combining medications like propranolol or midodrine with exercise or salt intake. How do you determine the best medications and interventions for a patient? So when I look at these, propranolol serves the purpose of, it's a beta blocker. So the beta blocker has a couple different roles. Primary role, it has some degree of vasoconstrictive capacity in the periphery. So we cause constriction of blood vessels in the periphery. And it also has the effect of slowing down the heart rate. So for people that are symptomatic with a heart rate, sometimes slowing it down allows the heart to fill. So the faster you beat the heart, the less it's able to fill back up and then pump more out the other side. So it kind of like per heartbeat, you're getting less blood flow. But if we slow it down, it can fill up a little bit more and be able to push more. There's more of an ejection fraction per beat. Cool. So that can be one of the effects. And then midodrine has the effect of basically causing peripheral vasoconstriction so that it allows you to return more blood to your heart. So both of these things are around just creating some opportunity to get more blood to your heart. And I would say that I'm biased because a lot of the people that end up seeing us are people that this doesn't necessarily work for, right? And then there's a cohort of people that are like, I just take these meds and then I don't think about it, and then I can get on with some of my activities. So there's a scale of people. So it's hard to know what is the approach. From my perspective, I get really interested in asking the question of like, well, why is the heart beating so fast? And if we can figure out why it's beating so fast and we can fix why it's beating fast, then we see that it stops beating so fast, right? And that's the simple way to put it. And if it's a blood pressure problem, we want to understand like, well, why is my brain not sensing my blood pressure correctly? And is there something I can do there that would allow us to make it work correctly to be able to solve for that? Now, so with that, we're kind of aiming for that highest degree of solution, which is like we just make the body work correctly and then we move on with our life. And then, but some people need some respite, or they need the ability to like feel some relief quickly, or maybe they're just not interested in pursuing that. Maybe it takes longer than they want. Maybe they're not interested in doing it, whatever the thing is. And that medication can be super useful in those cases. So there's a range. There's a range of people where it helps them have relief. There's a range of people where it doesn't. And then there's a range of trying to kind of, it's kind of like almost a philosophical basis of like, well, what's interesting to you? Do you want to try to solve the underlying problem, or do you want to just try to cover it up and move on with your life? So however that philosophy grabs you is probably going to dictate the direction that you run in. Now, you mentioned here that you're kind of nervous about taking the propranolol, which is reasonable. And that's probably something that you'd want to talk. And this is kind of that philosophical question of like, maybe it's something you talk to your doctor about and talk through the risks and benefits. And then if that doesn't sit with you, then you could try to look at alternatives. Dr. Kripos, anything we could add to that? Thank you, Nicholas, by the way.
No, I think that's a great response. And I also think it's interesting the way the question is phrased of combining the medications with something like exercise, when sometimes using both adding the medication can actually make it more challenging for you to exercise in a way that's comfortable. So it comes down to what you feel about that. And like you said, determining what sits right in your gut and having that conversation with your provider.
Yeah, I think that's right. And then friend of the channel, Gino here. Good to see you, Gino. But he gives a good example of that here. I take propranolol extended release daily. Helps to mitigate the symptoms in certain situations, but it doesn't affect having the actual symptoms. And I think, again, we're biased because of the people that choose to interact with us are going to probably tend to be the people that propranolol doesn't hit it out of the park with. That's just reality. But this is, I think, a good insight to what a lot of people experience. Thanks for sharing that, Gino. We appreciate that. Let's see here. I see some of the questions that are a little bit more kind of like Q&A type questions, and then I'm trying to go through the ones that are kind of relevant in the chat of our conversation. So one thing's like on this stream, we can kind of think about it as like we've got a chat of like we're communicating about something right now, and then things that are more like I've got a separate question that's in a different timeline, and we're kind of setting those off to the side, and we'll try to get to those as much as we can later. So I did want to get back to this other one, Dr. Kipros, because JP's asked kind of a follow-up, but an informed question that I thought was pretty good. It says, is it feasible to measure nitric oxide production as part of your autonomic testing, as well as NO and CO2? Are there other signaling molecules that you could measure or consider? I think it's a really strong question. I like the way you're thinking about that. And when you get into the world of signaling molecules, we realize like we don't know anything is kind of the basics of that in terms of not only identifying the molecules, but understanding how they all act both in different scenarios, but then also in different combinations. So it's kind of like a chemistry set where, you know, you get good at being like, if in a lab, if I put nitric oxide on this one type of capillary in this controlled setting, it does this. But then as soon as you throw it back in vivo, you realize all the cofactors and peptides and all the things that kind of assist that signaling molecule can really change the language of how those particular words are used, so to speak. Nitric oxide in the brain is kind of hard to measure because it'll work differently in different areas and in different types of vessels, which is kind of wild. But I like what you're thinking. So the reason he's asking this, I think, is I'm trying to crawl inside your head and I have no idea. But using nitric oxide as a mechanism is because we know it tends to have a vasodilatory effect locally. And what I mean by that, I'm going to use this. I'm going to do a little draw here. So you kind of got blood vessels that are larger, but then you have all the little tributaries or arterioles and capillaries that come off from them. And then those are going to go directly to some tissues, right? And we use nitric oxide as a way to signal inside those kind of more local areas. If this tissue is being used, then it'll release its own nitric oxide that allows you to dilate the local vessel, so you pull more blood in. And that is a pretty common mechanism, especially that we see in skeletal muscle tissue. When we get into the brain, we kind of started from the premise that we thought it was like, when I say we, I mean like science as a whole, neuroscience specifically, kind of thought like, oh, that's pretty much the same mechanism. But the more we read, the more we kind of understand about that, there's a little more gray area because we have these glial cells as intermediaries. So the relationship is a little bit different. It's like a really long-winded way of me getting to nerd out with you in public and really say that like NO2 is hard to measure, especially in the brain, and we don't know for sure to a degree we should, but I really like the fact that we're thinking about these signaling molecules as a way to understand, especially something like cerebral autoregulation and cerebral vasoreactivity, so that we can start to evaluate it more. One of the things that we do look at is we can look at changes in breathing and look at that relative on a transcranial Doppler to see if that causes vasospasm or if it causes changes. Another great way, just while we're on the subject, everybody just let me do this. is we can actually look at fundoscopy, where you look in the back of the eye. And when we look at the back of the eye, we can look at difference in arteries, the size of the arteries, the caliber of the arteries, and the caliber of the veins. And that's really cool because they change pretty dynamically. So normally when you look at the back of the eye, you get these vessels that come out of the middle of it, this place called like the optic disc, and they kind of come out like that, and you can see them in the back of the eye. And they usually run in pairs, so it's like arteries and veins are paired up next to each other. And when they're paired up next to each other, they should be about the same size-ish, pretty close. But sometimes when we see vasospasms, what it looks like is it makes it look like these veins are really fat, and then the arteries next to them are really skinny. And when we get that change, that's a terrible one. We got 3 out of 4, though. That's not bad. So these arteries will look very skinny by comparison, and we can see those vasospasms, and then we can measure that against like hyperventilation or deep breathing to see if they change. And that can be really useful as well. And then we also look at things like red saturation. Cool. This one doesn't quite work the same as just drawn on a regular sheet of paper because I can't erase it. But JPs, great question. Love to continue to nerd around on things like that. So thank you for the question. Jeannie says, when they made me breathe out and out and out, I literally thought I was dying. Oh, it looks like maybe this was a Valsalva test. Super useful test to measure baroreceptor activity. And baroreceptor activity is a huge part. Oh, sorry, we're going to make it a JP show here for a second. Because he asked prior to that, does the rate of cerebral blood flow drop off over time differentiate between the baroreflex issue versus cerebral vasodilation or sympathetic tone? We'll put sympathetic tone aside because I don't know if that's a good way to think about it, but it allows us to be able to detect differences in baroreflexes when compared to something like a Valsalva test like Jeannie you're talking about, and then also a deep breathing test. So we can see, I don't know if anybody was on the stream with us last week, but I showed this little kind of schematic loop of how some of these simple reflexes work, sending sensors from the carotid system to the brainstem and then back out to the heart to control those blood pressure responses or the baroreflexes. So when we overlay a tilt test with these features, with the Valsalva test, with the deep breathing test, it helps us get a better sense of, hey, is that nerve that would bring it from the artery to the brain, is that sucker working? Or is my brain reading this thing just way off? And is it kind of on both ends where we're not modulating pressure either way? Or is it, I'm cranking the heart rate, but I'm actually not affecting vasculature, or maybe I'm letting my heart rate just drop too low, or my vessels are getting too dilated. So like there's all these little nuances of it that we can pick up in those tests, and maybe we'll pull some of those up next time. Cool, great questions, guys. Thank you. Okay, I'm just scrolling through here, seeing what I missed. Another comment on the propranolol. Jeannie had noted that she has a harder time with meds, like adverse reactions to meds, and propranolol gave you some palpitations, which is, can be one of the things. Oh, and then it said, or Midodrine, or maybe it was worth. Jeannie, I'm chasing you around here in the chat, but I appreciate it. Okay, that's a question. Blood sugar, head pressure. Hey, we got Dr. Chris Sovey in the chat. Welcome. welcome. And we got some. Okay, so we're back to some more questions. Dr. Kipros, you take over and talk for a minute. What do you see here?
I see. Trying to look through them. I think there's some great questions that I think we'll get to after we go through this. Some of it might get answered by some of these things.
Yeah. Okay. So I think we maybe just settle this last part in just kind of reiterating this idea. And it seems like a silly idea, but in this world, I think the reason we're choosing to talk about this so early on in our conversations, and we kind of hit on it a lot, is because if I could influence one thing to change that I think would change more outcomes for more people around the world that are dealing with these problems, my like hill to die on would probably be moving from thinking about things as a heart rate problem to starting to consider like what's going on with my blood flow, and that might give us a better window into understanding, number one, why your heart rate is doing that, but then number two, can we ask better questions toward being able to solve the problem? And that's a big one. I think we're really interested in trying to solve the underlying problem, while we also recognize that maybe that's not where everybody's at in their journey, but that's kind of where we are at in terms of like where we want to serve. Is that a fair way to say it?
Yeah.
Okay. Corey Block back in the building. Love it. Thanks for joining us. So, all right. So we'll kind of hang it up there as far as this little portion goes. I think that drives the point home, is that we're really interested in trying to shine some light on like here's a more nuanced way to think about this thing, and if we think about it that way, if we have better questions, can we solve a different problem? If we solve a different problem, can we get to a better place in our life? And so we were going to talk about a little victory from this week. We thought we'd make that part of this because we want to just give people some hope. And we had a fun little story earlier in the week with a young lady getting some shower time. You want to talk about that?
Yeah, this is exciting. I think a lot of people can relate to this. We have a patient we've been working with for a while, and this week she came in and said that over the weekend she was able to run the shower, stand up in the shower, wash her hair, get out of the shower, do everything she needed to do, and do all of that without her symptoms getting worse. So huge win for her. And I'm sure a lot of people that are on this chat can appreciate just how challenging that is when you're dealing with some of the things we're talking about. So I don't know if she's on tonight. She said she might be, but yeah, if she is listening, you know who you are, and we're excited for you.
And how many years did she say it had been since she'd been able to do that?
Ooh, I think like 2 to 3 years.
3 years, yeah.
Yeah.
So 3 years, first solo shower. Super big round of applause. Patient in a decade. We love her. But I thought that would be fun to share, especially because of what you said, is so many people deal with that. And, you know, the heat of the shower, washing your hair, getting your hands over your head, standing up, not being in a shower chair. So like all of those things together, being able to do her hair, which, by the way, looked fabulous the following
day. Do.
Yeah, so we love it. And so just wanted to share that, highlight that. I think we will make it a point every time we do these streams to make sure that we highlight these victories. We got a bunch of them this week, actually. We just got a really good email, but we will maybe we'll share that one from the next time. Cool. Awesome. Okay, so what do you think? We've been at it for 48 and change. Should we get into some of these questions and then see where it goes?
Yeah, let's jump in.
Okay, let me back out here of this full screen so I can see again. Dr. Wife Claire Keiser over here just pounding the keyboard, helping us out. Again, does not want to be on camera. We're going to get her on camera one of these days. We'll probably have to sneak it on her, but we'll get it. And she's got the little one on her lap tonight too. Okay. So what do we got? We got. Sorry, I'm moving these things around. Okay. So first one that was on the list was, how does POTS cause small fiber neuropathy? Maybe that one's way up at the top. I don't see it, but anyway, I was going to try to pull it up and be fancy. But how does POTS cause small fiber neuropathy? And I think on one hand, maybe we're looking at the relationship between small fiber neuropathy and POTS, rather than POTS causing small fiber neuropathy. Actually, more often than not, the way that these two are kind of linked together is the opposite, where we see small fiber neuropathy that can lead to POTS. So Dr. Kupras, I want to let you shine here a little bit and explain that mechanism of why the small fibers are affected and what that can do to change, basically peripheral blood flow. Yeah.
Yeah. So when we talk about a small fiber neuropathy, we're looking at a couple different functions of those nerves. A lot of the times when we have people in, we'll test them using like a pinwheel or ability to detect temperature in the extremity, because those small fibers are what sends information up to our brain about like pain stimulus and temperature stimulus. But importantly, as it comes to blood flow, and specifically blood flow in the extremities, those nerves also control the local vessels. So we know when something like in the extremities, if we stand up, we want our body to do what it needs to do in order to push blood up so we can keep it in our head. So if we start to lose signaling in those small fibers, they also control the vascularity of those vessels in the extremities. So if we start to lose that, we're getting less signaling, and you go to do something like go from a laying down to a standing position, and we can no longer create that constriction, making it more difficult for blood to flow up to our head. Our head doesn't get as much blood as we want, and then our heart rates would subsequently increase based on our brain saying, I don't have enough blood.
Yeah, that's really good. And actually, the place you took that question is a little bit of the advanced place, because when you think about small fibers, a lot of times they are sensory fibers, the ones we're talking about. And one of the things that's not well accounted for in kind of conventional medicine is the fact that we use our senses, our perception or feeling, to be able to create the maps of our blood vessels to be able to push blood around, right? So that's that sensory component. If I don't know where stuff is, I can't feed it. But then the other part is the small fibers that we see with the sensory system are made up very similar to the way motor autonomic fibers are made. So they're kind of the same size, the same diameter, and they have a similar, well, they don't really have any myelin around the coatings of them, which makes them susceptible to different things. So we can use sensory fibers or small fibers as a corollary to autonomic fibers. So sensory fibers are, again, carrying information to our brain, but the autonomic fibers are carrying motor outputs, reflexes out to the vessels. So a lot of times when we see small fiber neuropathies that affect the sensory system, the same things that cause those to break down are also the things that can affect the motor system. We use more of the bedside style of testing because the alternative would be something like a punch biopsy, which, number one, takes time. You got to punch a hole in somebody, but also we're taking it's kind of like the size of a pencil eraser, maybe a little smaller, but we're just taking one little spot and we're looking at a biopsy. So we're kind of hoping that whatever the thing is that's causing this neuropathy has affected that little area that we're going to look at. Because what we're going to do is look at it and actually look to see like the count of how many nerve fibers there are in that area. And then that's how they judge if you've got small fiber neuropathy. So this is kind of like the way this would be documented in kind of an advanced testing scenario. But the problem set with that is we're relying on a very small area. But then number two, we're looking at a problem that may be systemic versus patchy versus relative to vascular compression versus neurological compression. So there's all these other variables that we can't account for. But if we actually just go through instead and just check all of these skin areas, and then we can map out like, wow, this spot on the arm sucks. from the knees down to the toes, neuropathic, right? Or, maybe it's only on the right side. These sort of things become more noticeable rather than if we just take a punch out of your left calf. So that's where small fiber neuropathy really gets important, and we see a lot of it. And what's beautiful is a lot of times people that have been diagnosed with small fiber neuropathy, there's not like a good, here's what we're going to do next. A lot of times it's just like, if you're having pain, we can give you some meds to make it so that's not so bad. But what we've actually found is a lot of people are very responsive to stimulation of the nerve, and that can be people of all ages. So that can be young people, that can be people all the way into your 80s, where we see these neuropathies have positive outcomes. So I actually get excited when we see them, because it means like, oh, I think we might be able to do something right there, which is pretty cool. So I hope that is a good question. I think I took it on a tangent as usual. You want to clean up anything else I need to add?
No, I'm happy you said that at the end, because we had a comment from Pro Hunt that said that's scary. And yes, a lot of the times when you get assigned or given a diagnosis such as small fiber neuropathy, it does seem very scary, especially when there isn't an immediate, okay, here's what we're going to do about it. But like you said, these things tend to respond so well just to stimulating them and giving more input. And we see these all the time at the clinic. So yes, it can seem scary, but it's actually one that is addressable, and we see it all the time.
Yeah. I'm going to add another piece to this. I think it's useful. The other thing that is not well accounted for is the fact that, so neuropathy just means like there's something wrong with the nerve. It doesn't say anything about why or what's going on or how severe is it or is it permanent. It doesn't tell us any of those things. And I think a lot of times we run immediately to thinking of like, oh, it's permanent, it's degenerative, it's only going to get worse. But sometimes we've seen cases where they actually have a punch biopsy positive small fiber neuropathy, but we can change central, meaning brain afferents. So we can do things like we can stimulate them with their eyes, and we see that it changes the sensation in their legs. So we can see the thing that we would expect to be like dead nerves, actually not. We can actually change it just by changing the integration in the brain, and we see changes in the legs. So sometimes we actually see things that are called small fiber neuropathy or neuropathy that are not really neuropathy. It's more of a signaling issue when we come up to the brain, and when we take care of that, we see that whole system be able to repopulate and return. So there's a lot of cool things that are available for people like that. Okay, I'm going to go to the next one. Okay, this one's going to have, so the question is, why do POTS patients have symptom flares after procedures with anesthesia? So I'm going to clarify this one a little bit, because number one, I wouldn't say all POTS patients have symptom flares, but there's probably a specific cohort of people that do after procedures with anesthesia. So I'm going to give you an example, and it's not going to be all the way conclusive because there's a lot of different ways this could happen. But I'm going to give you some things to consider. So number one, so we got some of our data around, so we will actually check cerebral blood flow when people are moving their head in different positions while they're sitting up. And what we'll find is that certain positions will drastically change, for the better or worse, the blood flow into someone's head. And so we had decided, because there's not really good normative data for our application. So what we did was we used data around another subset of testing where they were looking at patients that were having basically like heart surgeries. But when they had them, they would kind of lay them with their head crooked. And being like that for a long time, they noticed that a certain degree of them were susceptible to stroke. So they laid there too long, the blood vessel gets restricted, and they end up having a stroke in their brain. So they're like, we can't keep doing this. And so what they did was they did these studies, and they said, we figured out that people that have more than a 20% change when we turn their head, we're going to position them differently because they're more likely to have a problem. So that's the same value we use. So we're using like the don't stroke you out values, and we see a ton of people that have these significant drops that are bigger than 20%. So one thing to consider is whether or not the procedures are altering the position of the body in a way where we could potentially cause flare-ups from a vascular problem. The same thing from a positioning perspective, if we have people that are hypermobile or have ligament injuries or old neck problems or whiplashes, and same thing, positioning can cause them to have a flare-up relative to sensory changes from the proprioceptors in their neck. So those are kind of like, if we put them in the bucket of positioning. Then we could look at anesthesia specifically as a way of like turning down the current of your brain. So if we have someone we have a central problem, we have a centrally based dysautonomia, and then we just like turn the volume down a little bit, turn the electricity in the brain down, the probability that that system is going to work better is not high. And we may see some carryover post anesthesia. And then the third one is obviously if we have a tendency toward cerebral hypoperfusion, and then again we turn the electricity down, we decrease the functionality of the brain, there's a potential for residual loss after that. So again, I ran away with that one. Dr. Kipros, anything that comes to mind?
No, those are all great. I think non-specific to anesthesia, but anything that if you're already having trouble regulating blood flow to your brain, anything that's going to alter that or make it more challenging is going to have you see, or is likely to have you see, an increase in symptoms.
Yeah, that's a much easier way to say it. Nicely done. So I hope that answers that. But some of that is like, it doesn't happen with everyone, and it's not just POTS symptoms. So like a lot of people that have concussion, head injury, TBI also kind of fit that mold. People that have ME, CFS kind of fit that mold, tend to be a little more sensitive. People that have sensitive medications as well, or blood pressure related problems, also just kind of being careful with anesthesia. Doesn't mean you got to run away with it like it's the devil, but you just got to just like be aware, talk to your physician, let them know where you're at, and try to work through that way. Dun, 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 dun. Okay. Here we go. I think I saw this one. Let's see if I can pull it up real quick. How did I miss Clarice in the chat? Oh, she's going to be a guest soon. I don't know if she knows that, but she's going to be on in the coming weeks. Okay, so I'm going to pull this one up here. Okay, so here, this is kind of like a chiropractic-centric question. For those of you that have been to a chiropractor before, that some of this will make sense, others it won't make as much. But it says subluxation to C2, which is basically saying you have the second vertebrae down in your neck. The way that your body controls your posture, it uses a different positioning of that vertebrae to kind of keep you stable. So whether that's the problem or whether your brain is saying this position works best for me, could be either side of that coin. But it says affecting the vagus nerve, giving dysautonomia symptoms. Upper cervical chiropractic is starting to help. So basically adjusting those segments to try to stimulate those joints and muscles so that your brain is able to recognize kind of the error in its ways better. And then as it does that, the communication improves, and the muscles that surround that joint are able to kind of control it better, which allows that joint to be kind of stacked more appropriately, like stacking blocks. That's a simple way to think about it. So I think the question is like, can that happen? And the answer is yeah. So the vagus nerve, so you have this thing called your carotid sheath here. Dr. Kipros, do you want to describe kind of what's in that sheath and why the C2 may be affecting that vagus nerve?
Yeah. So we have the carotid sheath that runs down your neck, right in through here. And it actually relates really well to what we're talking about today, because in that carotid sheath is the vagus nerve, which you've addressed in this question. But then we also have the carotid artery, which we discussed a lot today, and then the jugular vein, which also all run in through that same area in the neck. So probably what Dr. Keiser is going to get into is that if we have compression, which could come from a subluxation or some sort of misalignment of the joints, compression in that area, you're not just going to have an effect on the vagus nerve, but you could have an effect on all three of those structures that lie in through there.
Yeah, I think that's greatly said. So anytime you're kind of having to wear different hats when you think about autonomic system, because it exists from your brain all the way down to everywhere in your body. So one of the reasons that it's so important is the autonomic system. One of the main jobs it exists to do is to control blood flow through your entire body. So you only need to have sympathetic nerve fibers just in the places where you also need blood to go. And if you think about it like that, it's like, oh, they got to go everywhere. And oh, they're also all controlled from one central structure. So there's like one thing in charge of like all of it at the same time. And it's all being done moment to moment. So it's kind of like there's a lot to do there. And then so you realize in this case, we've got kind of like a structure hat where, hey, those are cables running through. Sometimes structural things can impair them. And it only takes the weight of like a dime to impair the output of those nerves, right? And that can be from nerves coming up to give us information or from nerves going down to take information where they're trying to go, right? So you can think about that from a structure perspective. But then we also have like this idea of fuel we talk about in that cardiovascular system. So are we able, even if something may work, but if we cut off fuel to that area, just like gas in your car, it doesn't work. And then we also have to think about in terms of the neurology. So like, is there something wrong with the actual neurons or nerves that prevents that signal from being transferred effectively, right? So all of those are kind of like different hats that you'd have to wear. And then on top of that, you can put, other things like, do these particular organs work correctly? Is your blood sugar stable? Do you have anemia? Like, are you able to carry oxygen effectively? Do you have carbon monoxide poisoning? Like, what's going on? So like, do you have an infection? Do you have a parasite in your gut? So all of these things you kind of have to put different hats on as you're figuring out these problems. But I think one of the things that we struggle with is, as practitioners, you kind of get on a good idea. So you'd be like, I had this one patient one time, and she had mold. And then when we got rid of the mold, her symptoms all went away. And the temptation is to go like, I'm going to be a mold doctor now. And everybody you look at, you can't get that mold thing out of your head. And then, so that's like the only thing you can see. And I think we are so susceptible to that. It's really hard to like, so like one of the things we have to do is like, you have a thought, like, I think it's this. And we do this. So in the mornings before patients go in, we have a huddle. We meet, we talk about the case. We think about like, what are the options on kind of things we need to look at, make sure we don't miss things. And sometimes we'll have a read and like, this really sounds like this. And as soon as you get the thought in your head, you have to go, okay, I think it's this. We have to immediately try to prove that's wrong. Because otherwise what you'll do is you'll try to prove it right. And that's easier to do because you can kind of like shift things to fit into the mold that you want it to be in, because that's the thing you think it is. But it's really important to try to kill your best idea. Because if you do that, you're always looking to try to put a different hat on to try to find, okay, I have to rule all these other things out before I can go to my original idea. And that's really helpful, because a lot of times we'll think, I am guilty of saying like, I think it's this. And then I will get that person in front of me and I can prove it's not that. So then I got to hunt for the thing that it is. Anyway, Dr. Kiros, I'm not sure how I got onto that topic. I hope it's useful for someone. I believe it is. I believe that was useful for someone. I'm not sure who, but I'm going to hold to that. Should we go to the next one?
Let's go to the next one.
All right. Here's a good one. I've had POTS for 20 years. Weird question. Ooh, I like that framing. I have an issue when I hang my head upside down for even a few seconds when I get on the inversion table for back relief. That's kind of a notable one. What do you think this is? My head gets really bad pressure and hurts immediately. Now, I don't know what it is. I would really like to look at it though, because I got some ideas. This is like a perfect segue into the thing we just talked about, isn't it? So the questions we would start to ask is like what kind of head pain it is. You know, is it sharp and stabbing, or is it throbbing, or kind of what is the quality of it? Does it get better right away when you sit back up? You said it's pressure. Does it change? You know, does it change your vision? Does it change your hearing? Does it change vasculature? Does it change pulses? What happens? And then we start looking through: is there, you know, obstruction of something that should go in or out of the head? Is there something that's more sensitive than it should be? Is there a problem in your neck? And on we go, kind of just like through this thing we just talked about. So I can't diagnose this one. If I'm honest, I'd really like to look at it because I think I have an idea on how to help it, but I can't do that through this venue. But that's at least a start to start thinking about some things. Okay, blood pooling in both hands and feet. How do you correct for that? It's a great question again. So without going through all the differentials, what would be, and obviously we can't just say, well, you just do this thing, because there's not that answer. But how could you help someone start to think about why might there be some blood pooling? Why in both your hands and in both your feet? What sort of things could we start to think about, questions we could ask ourselves to be able to get toward that answer? What are you thinking, Dr. Kipros?
When we start to think about that, I start to think of, well, what are the mechanisms that would allow us to both bring blood into those areas as well as push blood out of those areas? So if we're having blood pooling, a lot of the times we're looking at, okay, we're having a difficult time pushing blood out of those areas. And what are the mechanisms that control that? Obviously, everything comes from the brain, and the brain telling us where we need to put blood. But then can we also get the message from the brain and activate the correct mechanism in order for the blood to move throughout the body the way we want it to?
Yeah, I think that's a really good way to put it. So I am going to do like a little bit. I didn't realize you kind of had to do this in a live, but you do. So I really like the contributions from Jeannie, but also Jeannie, I got to call you out a little bit. So we can't be diagnosing Bob with hyperadrenergic POTS in a chat. I don't feel like that's probably going to be the best way to do that. And I also don't think it's true. So with those two things combined, I love that you're contributing. I love that everybody contributes, but let's try not to diagnose each other. I know it's out of love and we're trying to help each other out. Totally get that. But one of the things that we risk with doing that is sending someone down a path that may not serve them. We actually may cause more problems than not. So I love the help, but also let's all do each other like a beautiful thing and not try to do a chat diagnosis. I don't know anybody that's that good. So let's try to win every race if we can while we help each other out. Cool. Thank you. Let's see here. And then I think piggybacking on the question we had about bending over is this one from QQ. My tinnitus gets louder when I bend my neck back and I push my jaw forward. And this is kind of along the same lines we're looking at when we're tipping back, and what you're describing here, especially. So things to think about is when you do a physical movement like that, especially one that's this specific and you're able to bring it out, then you want to look at, these are where we start to bias toward thinking about structural stuff. So things that you could start to look at would be, okay, well, why tinnitus? So tinnitus, is that going to be a neurological problem? Is there a peripheral nerve? Is that all happening inside my skull? And the second part to that is sometimes if we see that pressure can't drain, so blood or cerebral spinal fluid can't drain out of the head and it creates more pressure going out, we can get a tinnitus that's pulsatile. So it's like a pounding sort of tinnitus that gets worse. And if we let that internal jugular drain and it gets better, that can be a thing. So one of the things that can be handy is having a duplex ultrasound done where you look at how big around that internal jugular vein is when you're neutral, like not having that tinnitus, and then put yourself in that position and you want to see if you're having any changes in that vascularity. And that can be a test that you can have run. And that might give you some insights in how to solve that and maybe tell you what is the second part. So number one is like, can we prove that that's true? And then the second part would be like, well, what's causing that? And then how do we reverse engineer that and back our way out so that I'm not having that sort of problem. But again, you got to differentiate a couple things to get there. But one of the things to rule out is I could rule out having that test done, get the data. If that's not the problem, then you move down the line, solve the next problem. If that does seem to be it, then you say, why is that happening? So just a way to start to think about that problem. Okay. I'm going to try to stay in order because I will get out of order quickly. Okay. Ooh, Bob. Welcome. Thanks for being here. The question is, I can't find it. Are you getting all? You're not getting the Facebook ones, are you? Okay. Okay, so where was I? Would you quickly be able to explain why blood volume is lower in POTS patients? So really great question. So if you spend time in literature, what you will see in several papers that suggest, particularly from a 2005 origin, that blood volume is lower in POTS patients. And then, so it's a tricky thing because it's really hard to measure blood volume. And the tools that we use to try to measure it, we're kind of using a proxy extrapolating measure. And that's not to critique the people that are doing it because it's a really, it's a big deal to try to figure out. But if you think about it, measuring blood volume is difficult without draining your body of all the blood and then measuring it and then putting it back. And I know that's like a pejorative way to say it, but what I'm saying is like measuring it on a circulatory basis is very hard. It's hard to count. It's like trying to count, all the people in a stadium and they're moving around and everybody's changing position. Like it's hard to do. So that's number one. And then, so why might blood volume be lower? So we could have absolute blood volume be lower. If that's true, then we could see like the overall blood is lower. And that can happen if we have problems with our ability to detect our own blood volume. So like we don't know how much, our body's not accurately detecting how much we have. Then it doesn't activate the normal systems that allow us to retain fluid or expel fluid. Typically in this case, we're talking about retaining fluid. And that is an action that primarily happens, it finishes up the process in the kidneys. An interesting thing that kind of always sticks in my head when I think about blood volume though, is the idea that, so the right atrium has volume receptors. So the right atrium is like the top right chamber of your heart. So you got the atrium are the top two, you got a right and a left. And then the bottom two are the ventricles. So you have a right and a left. But the right atrium is kind of where all the blood that's coming back from the body goes into the heart. And that right atrium has sensors that detect the amount of blood, or the amount of pressure that's there. And it can, based on that signal that comes from the right atrium, it can detect fluctuations as little as like 1% change. So that's always stuck in my head, because if that works, then we shouldn't see this downtrend cascade where we deplete the blood volume enough to where we're not getting it back to recirculate to the brain enough. Like, so if you think about like giving blood, how much blood do they take when you give blood usually? Like if you're going to Red Cross, do you know?
I have no idea.
Like a pint, maybe? What do you think? I don't know the answer to that. I don't remember. There you go, guys. I don't know that. But anyway, you just think of like we're removing a portion of your blood. Maybe are you hunting that one down?
Sure.
So we're removing a portion of blood, but you can still get by. Yeah, like they say, like maybe don't go work out. You sip apple juice and like don't do anything crazy for a little bit, and then you're on your way, and then you live your life. So with that, then that always makes me think about, well, number one.
Approximately 1 pint.
Ooh, I was right. I think I was.
Half a liter.
Yeah, 1 pint, or in Canadian, 1/2 liter. How do you guys measure fluid? Would you go pint, or would you say liter?
Liter.
Liter, for sure. Okay. There you go. Problem solved. This is just, I asked Dr. Kibros a lot of these questions about metric and standard measurements. Okay, so basically, so we're back to this idea of if it is absolute hypovolemia, to what degree is hypovolemia problematic? We normally have these sensors that allow us to detect pressure every heartbeat of your life within 1% range. It's like it can detect changes to that degree. So what I start to think about is like if let's say we do have hypovolemia, it's hard to measure, but let's say we do, and it's not dehydration, and it's not your salt intake is weird. It's just the natural way that your body's trying to maintain volume. Then the question to me would be like, well, why are we interpreting those sensors in that way? So is this a neuropathic problem where the sensor doesn't work? Is this a kidney problem? Is this a problem where the nucleus tractus solitarius in the brain isn't working as well as it should, and it's not detecting that number appropriately? So it's like it'd be like if your gas gauge wasn't working quite right, and it told you had a full tank, but maybe you got 3/4. It'd be kind of like that. So I guess I would start to answer that question by saying like it's really hard to measure blood volume in a way that is it's like passes a sniff test. You can do it with some imaging. Those things are, I mean, I've read all of that. I understand it. But then also I would tend to drift toward why are those sensors not working? Why is it not being regulated? And then try to solve the regulatory problem. Okay. If I think of other ways that blood volume could go down because you're bleeding, could go down because you're dehydrated, could go down because you're sick, because you got problems with your kidneys. Those would be kind of the big ones. Or you have such bad swelling in the periphery that you're losing all of the plasma volume in the periphery. But that's kind of the simplest way to think about it to start from. So I think it's a really good question. I think it's something that we're continuing to explore. I read about this every day because it's part of this problem we're trying to solve for, is because that is such a pervasive thought. And if we are actually measuring it lower, then we want to talk about areas in the brainstem, in the NTS, in the area postrema that would allow us to detect blood volume better. And that's the way we think about it. Cool. Anything to add?
No.
Sorry.
That's a good one.
Oh, sorry. Oh, okay. This is a question that I've actually had a few times lately, which is, have you ever seen POTS get better after a virus? Had a bad case of the old influenza A, in January of 24, and felt better with POTS than in 20 years. Usually after a sickness, it's worse for me, but it's better this time around. So one way to consider to think about if you see a problem like this, we also would see these sometimes after vaccine, where it'd be like, whoa, I'm great. And then sometimes it holds, sometimes it doesn't. But it may be something to look at with if I was thinking about this problem, I might think about like how well the immune system is working at being able to detect and activate. So by getting sick and activating that immune system, if activating the immune system starts to make you feel better, it would make me think like, as a corollary, if your immune system activation is helping, there may be something that's going on in the background that's kind of like a chronic infection or chronic thing that's going on. And by activating the immune system, we kind of address some of that underlying, just by luck and chance, or we've got like low levels of immune complements, we're just like a hypoactive immune system, then those are the things that I think of in those cases, and where we start to evaluate a little bit more depth on testing with the immune system. Anything to add?
No, that was a great answer.
I'm gonna have to start letting you go first. I'm sorry. Okay, here we go. It's coming your way. Let's see.
Okay.
Why is it so hard to regulate body temperature with POTS?
Ooh. Well, we have to think first about what allows us to regulate body temperature, and all of these things are autonomic functions. So when we talk about being under the dysautonomia umbrella and not being able to regulate or have those systems work the way we want to, temperature regulation is a huge part. So this can come from being able to pull blood out towards the skin to dissipate heat, as well as being able to sweat appropriately and in the areas we want to be able to sweat. So we have a lot of people who these systems aren't working because the underlying functions of being able to move blood throughout the body, or too much sweating or too little sweating, and able to regulate our internal body temperature, those things aren't working the way we would want them to.
Yeah, I think that's a really good way to put it. So you got to be able to detect the changes. Also, we see hypothalamic changes. So your frontal lobe really drives a lot of what happens with these reflexive outputs from the hypothalamus. And if we can't generate that, then we have these real difficulty with being able to control for it. The second piece of that is we also affect outputs from the thyroid, and that also we see big trouble with thermoregulation when it comes to that. But that's the simple thing, right? So being able to move blood towards your skin, away from your skin, as ways to compensate for it, being able to sweat, not sweat, and then being able to be able to have your brain running hard enough to be able to kind of hit the thermostat, so to speak, so that it doesn't, we don't let it get so far out before it doesn't. And then the other part is just like you said, everybody's probably experienced when you cut blood supply off to an area for a little while, what happens? It gets white or purple or cold. So so many of the people that we see just don't push blood around very well. They've got some of these things we've been talking about all night, and those extremities get super cold. And then the ones that have trouble with heat, like you said, it's just sometimes hard to sweat. It's hard to move blood. We're already saying it's hard to move blood. So one of the best ways that we dissipate heat is to push it into your skin to be able to convect the heat back out. It's like a dog panting and sticking their tongue out. So you get some surface area to get some of the heat. And then if we're already not able to get blood flow to our brain or to our extremities, the ability to then push it into the skin dissipates. And then you fight this problem of, if I push it into my skin, that takes it out of my brain. So then I start to feel dizzy and gross. And so being in the heat super hard. So really good answer to that one. Let's see. Has anybody come in with problems with a simple solution? Has any patient come in with a problem, with a lot of symptoms that have a simple solution? What would you say there, Dr. Kipros?
It depends on your definition of simple. We talk a lot, like we're talking a lot here about like all the testing we do and all the diagnostics we run. And yes, that initial exam is a lot, and it's a lot of diagnostic testing, and it's a lot of objective information. But then I think sometimes patients are surprised to see that what we give as the solution or the treatment method is actually a fairly simple treatment. Like, we're not trying to be out there doing some crazy thing. We're actually trying to go, what is the simplest, most effective way to treat the area of dysfunction? So yes, all the time we have people who come in with this wide range of symptoms, but when we can narrow it down to the underlying cause and not trying to address each individual symptom as it comes, it's kind of a losing battle, because you're going to address one, the next one, the next one, the next one. we're trying to find a treatment that's what's the simplest way to address the root cause of the dysfunction.
Yeah, I think that's a great way to put it. It feels like, I think most of the people that come in feel like they are the most complex because there's so much going on. There's so much that impacts their life. There's so much that's not going great, and it feels like it's coming at them from everywhere. But so many of them have a problem that is causing lots of downstream things. And we're all limited to a human body, which means there's only so many ways to interface with it. There's only so many types of receptors we respond to. There's only so many ways to activate a sensor. So what we actually find is simple is kind of the only way. If you're sensitive to the world because everything is hard and everything is overwhelming and everything is too much, adding more or making things difficult doesn't help. We actually have to go to like the simplest version of everything. So it makes me think of like, today, just like one direction of moving your eyes, one direction of turning your head, one place of applying electrical stimulation to your body, and being able to ramp those up slowly so that the dose matches what their brain can tolerate, so that it can get stronger. And the analogy that we use all the time is weightlifting. So if the goal is to bench press 300 pounds and you can bench press 100 pounds, we probably won't succeed if we just keep putting 300 pounds on the bar and then just saying, all right, give it a run. Hopefully you don't drop it on your chest today, but you will. But instead, if rather than do that, that's going through your life, right? Is like, I'm going to get up today and just try to do it today. And then you just drop the bar on your chest. But if you can say like, oh, I can do 100 pounds. And so maybe tomorrow I can do 105 pounds. So that's like, okay, I can do this one head movement and my vestibular system tolerates that. But then tomorrow do 2 and then 3 and then 4. And the next thing you know, I'm like bending over, picking stuff up, and on you go. That dosage matters. So I think you're exactly right, is that like, not only are these complex presentations, are we looking for simple, like it has to be simple. And that doesn't conflate simple with easy. So I think that can be a thing we could screw up. So like, we're saying it's simple because it's not complicated, but it doesn't mean it's easy. It usually means that someone's going to have to do the work to get stronger, which is effortful. Not necessarily hard, but it's effortful, but it's usually simple as well. So yeah, I like that. I really want to be able to answer this one, but I feel like I'm going to fail at it. But I'll try. Causes of extreme fatigue. Tests you could do to determine this. And does that help you determine treatment options for fatigue? So fatigue's part of all of them, isn't it? So go ahead.
I think if we're going to stay broad with it, and this is something I've heard you say, I like to repeat it to patients as well, is it takes a lot more energy to run a dysfunctional system than a functional system, right? So if we have everything functioning the way it's supposed to, that leaves us a lot more energy to do the other things that we want to be able to do. But as soon as we're having to compensate in the various different ways for a system that's not running functionally, we're not going to have the energy to do the other things we want to be able to do in our life.
Yeah, that's a very smooth way to say it. I like that. Everything's harder. Everything takes more energy, and you already have less juice, so you have less battery to run off of before you crash it. So like if you start from there and then you're going like, what test do you do to determine this? That's kind of like, that's a tough one for me to answer because it's kind of like all of them. And then the hunt is to try to figure out what is at the core of it. And I would even go so far as to say a lot of times we'll see people that will say like, we got to solve this problem first so that I can even tell what the other problems are. And a lot of like the common one is like, you have a 50% drop in blood flow to your brain. everything looks bad. So like you move your eyes, it looks bad. Your balance is bad. Everything's bad because you can't get any juice in there. So like the first thing we have to solve for is we got to get blood in there so that we can even see if there's another problem underneath this. And, you know, and that may be the case, or it may be an infection, or it may be that it could be all of the things like we talked about with the different hats. So I find this one to be a really tough question because usually fatigue is just part of anything that affects your brain. Anything like even getting the flu makes you tired, right? So like almost anything makes you tired. So that's hard. I wanted to shift to asking this one. This is a Facebook one from Chris Boyce. Actually, seeing it on Facebook, we've been at it for like an hour and a half, which I'm having a lot of fun. I'm super happy to have Dr. Kipros. I've got my wife, Dr. Claire, here as well. If whatever you're watching this on, it's on Facebook and YouTube and X. If you wouldn't mind just like whatever the version is of liking that or like saying hello or just interacting with it in a way that it makes it so other people like it signals like, oh, other people might like this too. If you could do that, that'd be really helpful. I appreciate it. It just helps us be able to like have a little better audience so that we can like share at a larger scale, which is ultimately the goal. So there's my little, what do you call that? Do we just do like a telethon? A little sales pitch. So that's that. Anyway, so I'm going to share this one. This was a Facebook one. Chris Boyce, thanks for sharing. What suggestions do you have for people with sensory overload problems? I tried prisms, FL41 glasses, which is a tint, hats, earplugs, vision therapy, still having problems. I'm super sensitive to that because so many people have been in that position. I'm going to let Dr. Kipros take a swing at it first, and then I'm going to clean up from there.
I think, some of it can be related to what we just talked about in the previous question, is if our brain isn't getting enough energy, and how do we think of energy? We can think of that as oxygen getting to the tissues to integrate information the way we want it to. Everything is going to push us outside of the threshold that we can properly integrate that information. So I know we see this a lot in the clinic with people, sometimes with people who do have such a decreased blood flow to their head that the brain trying to integrate that information, take it in through a sensory perspective, process it, it becomes too much or overwhelming for the brain to be able to do that because it just doesn't have the energy. So instead of being able to process, okay, I want to take this in, I can process it and then I can have an output, everything is just flowing in and it becomes really overwhelming.
Yeah, I think that's a good angle to look at it, especially when I think about like the cutting of my teeth was all done in brain injury. So I like to think about these as like in a broad scale as a filtering mechanism. So so there's always information that's coming into the brain is a good place to start from. But what takes all the energy is actually filtering out the things that don't have meaning to the current task and to being able to focus on the bits of data coming in that are useful in that moment and be able to shift and predict what's going on. So anytime we affect the brain's ability to be able to onboard that information and filter it out, we end up burning a bunch of energy and we become way too sensitive to things because there's too much coming through. So these are especially common when we look at problems in cerebral or Purkinje output, problems that are occurring in a couple different components of the basal ganglia, where the job is to take all these sensory inputs that we're dealing with and to be able to filter them out effectively and just let through the ones that we need to use in the moment, and to be able to do that dynamically while predicting the next phase at the same time. So when I read this one, you say sensory overload, prisms, for instance, are saying like, I got two eyes that are not aimed in the same direction. So I'm kind of using like an orthotic or like a crutch to bend the light so that they both end up matching my retina in the same place So I'm not trying to interpret two different visual worlds at the same time. Two different cameras aiming in opposite directions makes for a very complex world. So with that, the question would be like, what is the underlying? So like trying to use a prism would suggest like I've got something wrong with my vestibulo-ocular system, my ability to be able to guide my eyes in appropriate relationship to my head and to gravity. And that'll cause a shift in the positioning of the eye. Changes in the lens may actually change the color inputs that come into the eye. And this is a little different thing. So this is happening in the midbrain, my ability to filter through the midbrain to my thalamus. So those are kind of, it's like a separate problem that would be solved by the prism. Using a hat is just a way to give yourself a blinder to limit some of your field. So the overall central and peripheral retina being able to take in and interpret that information. So it's coming from your retina through the projections to the back of the brain. Earplugs, a similar idea. I'm blocking out an amount of sound just like I'd be filtering my lens or using my hat. So the filter is going to change the color, whereas the hat is going to change the amount of movement or the amount of like scene that's there. But either way, there's still filters. Earplugs are going to be a filter as well. So and then vision therapy is kind of like you're assuming that the way that your brain is tracking your eyes, we're going to do some things with vision therapy. Vision therapy is a super broad term, so I don't know. But in most of those, what we're looking at is a way to reduce the stimulus, which I think is smart, especially from like a respite or trying to get some relief position. My bias is to use those things in conjunction with what you're talking about. Things like vision therapy, where you're actually trying to solve the underlying for them. I'd be really curious because you're obviously asking for a large number of people and probably for yourself in some ways. The curious question would be, how could you make it more specific? So for each person, how could you make it more specific? So when you think about vision therapy, how could you dial it into the most direct way to affect the area you're trying to affect? Meaning, when you say, am I trying to just improve a concussion because I think there's something wrong with my brain? Or are you saying it's because it's in the left frontal eye field in this little portion of my brain? Or if it's these, deep cerebellar nuclear outputs from the vestigial nucleus in the right portion of my cerebellum? I think that's where you gain traction, is to start to say, take it away from like my brain is injured to like zooming that sucker in and seeing like where in those pathways is it injured and how do I start to address those pathways. And I think that is probably the next step for people that have kind of done the gamut of things like you're talking about. And it takes a long time to go through that. Like once you've kind of done all of those things, and if you're just not catching traction, then I think the next layer is you got to get really specific about where in the brain I'm trying to target and be specific about that area and try to objectively measure that improvement in those areas. And that's the way I would go forward. That would be my suggestion, is if the broad stuff doesn't work, you got to dive in and try to answer better, like get way more nuanced in the area you're trying to attack. And we have some colleagues and ourselves that's the way we think about it, rather than thinking about, we don't want to think about the brain as like one organ that only functions as one thing. We want to think about how all the individual pieces of it work together. So really great question. Thanks for what you're doing. Wish you a lot of luck on that. All right, let's see. Hey, what do you think about this one, Doc? Pro sauna for POTS, like pushing yourself through the heat. What do you think about that?
I think generally, I think we get asked a lot about things like sauna or ice baths or kind of some of these mechanisms. And I think generally they're great tools. They're just not great for everyone at all times. So heat's going to be a tough one for some of the reasons we talked about earlier, as if you're already someone who's struggling to move blood throughout the body in a way that's going to keep it in your head, heat that has that like dilatory effect on especially the blood vessels in the periphery is going to make that more challenging. And if we haven't addressed the reason why those systems aren't working properly, it's going to be kind of a slog to get through, just trying to push yourself through it. It might be a great goal to have of like, I would really like to address this so that I can use the sauna in a way that's going to be beneficial for me. So it kind of depends on where someone is within that journey.
Yeah, so you're kind of like trying to solve the problems in order. So we're really big though on not restricting people's lives. It's like that's a huge part of the way we think about it. So we have learned that the more stuff people take out of their lives, the harder it is to put them back in. So like, you know, you stop walking and you start to use the, you know, when you start to use the chair, sometimes it's harder to get out of the wheelchair, or sometimes it's harder to get out of bed if you've been laying there for a long time, or it's harder to, you know, on and on and on and on. So I tend to have this, this predisposition toward like, if you can do it, keep doing it. Like if you can be outside and it's warm, and even if you got to come in after a bit, like to the degree that you can do it, keep doing it. And I like the attitude a lot of like, I'm going to try to push myself. So I love that. I know Dr. Kibros does too, for sure. And so I do think I like the idea that you're like, I'm just going to try to push it. And I don't mind that attitude. I also think trying to do it in a way where you're trying to objectively move the needle. So to be like, let's scale it to what I can do. And then just keep, you know, almost like training yourself to be able to deal. There's this interesting paper I read, it's been years ago now, where they looked at using contrast therapy of basically like if you had a hard time being in heat, for example, what they would do is they'd have people have most of their body out of a hot tub, and they would start by just like putting one foot in or one hand in and being exposed to the heat, and then until their skin got red, and then taking it out and then doing another body part. It's like doing one part at a time, because your body's able to dissipate that heat a lot faster and to be able to like tolerate it, and you're doing it in segments. And they were able to use that as a technique, both for hot and cold. But I kind of like that part of me, it sticks through. So it's like, if your one job is you want to solve heat, then the way that I would think about it is, we'll find the dose that you can tolerate and start moving forward to train your body to be able to understand the differences in those temperatures. But ultimately, like my biggest bias is just what Dr. Kipro said, is like, let's try to figure out why, you know. We've talked about thyroid a couple of times. Like, we should check that out. Make sure that's not a thing. We should make sure, you know, blood sugar's good. We should make sure brain's working. All the things that come with that. And I think that's a good place to start. And someone had asked also if POTS is a thyroid issue. Typically POTS, no, not so much, because of the fact the orthostatic component doesn't tend to be like, if your thyroid's not great, you can have tachycardia, you can have palpitations, you can have kind of some of those cardiac based things. Like if you have palpitations, for example, you go to the cardiologist, you're going to get a thyroid panel for sure, and you should. But if it's specific to the orthostasis, it's less likely that that is the culprit. Although that doesn't mean that you shouldn't check it and you shouldn't try to like solve whatever problems you have with your thyroid. They're probably not going to harm whatever's going on with the orthostatic part. So just for what that's worth. Okay, so Dr. Claire Keiser had to go pick up our middle child at gymnastics. So we are solo on the chat here.
Okay.
Well, we're not solo. This animal here is with me. She wanted to say hello. So this is the littlest one. Oh, now you're shy. So she's been sitting in the co-pilot seat over here, just being real good. But she wanted to say hello. You gonna wave? All right. Okay. Co-pilot, go get it. So she's keeping everything under control over there. And we're now in charge of the chat. Okay. Can blood pooling in the legs and feet be caused because the blood vessels are damaged and not just because of the vasoconstriction signaling being wrong? Sure, you can have damage in blood vessels. You'll probably see it. And in terms of damage, could be severe damage, like you could see it, or it could be the fact that you have like problem with like endothelial activity. But a lot of those things are like relative amount of damage too, and they impair the ability to vasoconstrict. So one way that fits in my head to think about it is, even if you take a vessel, I wish I had my drawing set up here. So even if you take a vessel and you think about it being a tube, but it's a tube with muscle in it, especially if it's an artery, not so much in a vein. Veins are kind of like floppy hoses. But the arteries, if you take an artery and you inflame it, you swell it, right? You just irritate it, make it mad. It's going to act like, well, what happens if you have swelling in your ankle? It doesn't move very well. Like, it gets stiff and it doesn't have the same range of motion. So you can think about a blood vessel the same way. So if it swells, it's going to impact the size of the hole on the inside, right? The size of the tube as the thing swells. It swells on the outside, but it also swells on the inside. So if I do that and I make the tube smaller, that's going to be problematic. But then also, when I swell it, it's harder for me to constrict and dilate it because it's swollen. It's like you got a swollen hand. It's harder to be able to make the full range of motion. So that's another thing to consider and think about is, damage is a tough word because we make that feel like it's broken, but it may just be the fact that it could even just be irritated or not working effectively, or the same way we would think about skin or bruising or irritation like that. So damaged vessels usually leak, and they are a lot of times you will see that through the skin. Seeing vascular, if that's the case, then there are vascular specialists that are really useful for those things, especially varicosities in the veins and painful veins and stuff like that. But the kind of pooling that we're talking about here is probably more relative to dysfunction than to an all-out like fracture of that system. What do you think, Dr. Keeper? Say I get everything there?
Yeah, I think so. That was great.
Okay. Let's see. Can elevation make a difference? So if you are at a higher elevation, can that affect symptoms? We do see that to be the case. And I don't practice at a higher elevation, although we do have some colleagues that do, that we talk to a whole lot and work with a lot, that will describe elevation changes causing problems. And a lot of that is, again, back to this pressure regulation thing. So if I don't detect pressure super great, then I may, alterations of pressure or things we see at altitude can make them worse. And we've had patients that that feel well and then travel to altitude and then have some problems, and then we kind of have to coach them through those things as well. So I think that elevation change specifically can definitely be a problem, especially if we've got anything that's sensory based. So vestibulopathy, cervically related problems with oculomotor problems, that these things that integrate pressure systems or baroreceptor systems, otolithic systems, that can be more sensitive to those pressure changes. Stuff that affects your ears, so to speak. So Mary, I'm going to pull this one up because it's longer. You guys can read it along with me. This all makes sense. Thank you. These are neurological issues and most times not cardiac. And that's a really important part, because a lot of what we see with POTS is we're saying it's not cardiac. So that's like the starting point, is saying like, this isn't a heart problem, it's an autonomic problem. So to be able to fit the criteria of POTS, we're saying definitively like, this is not a heart problem. I wonder why this material isn't being taught more as a first line approach in treatment instead of meds first. That I can't comment on, but doing things like this is the hope that we go. So that somebody just goes, you know what? Maybe we could think about that. We could start doing these things. We could start interfacing, and that would be just such a wonderful goal if we move the needle in that way. Yeah. What's your thought on that, Dr. Kipros?
I agree. I think that it's hard to comment why other people are doing things or aren't doing things in a specific way, but I think our goal in doing this is just to provide the people who may be in this situation or know someone in this situation or have a loved one in this situation, giving them or giving you a little bit more knowledge so that the next time you go to one of these providers, you can ask a question that makes them think about it a little more, and you might be able to get to the next step even if it's just a little bit sooner instead of having to wait as long, or if it gets you a little deeper into understanding why something is happening. That's why we're doing things like this, so that people can feel a little bit more autonomy in their own care and their own treatment and understand why things are being done and the right questions to ask. And if you have that gut feeling of, I think one of the questions mentioned before, like, I'm just nervous to do this. If you have that gut feeling, trusting that and saying, okay, why do I feel like this? Is there a deeper question that needs to be answered here?
Yeah, I think that's a good point. I think we're actually at a really exciting time right now because we've kind of been through, like, this big arc over time has been the idea of like medications and chemistry and as a solution. There's like a really romantic notion about the simplicity of like, man, if I could just take a pill and this would go away, that would be amazing. And we've been like chasing that dream for so long. And then I think we're kind of at this stage here at the beginning of 2025 where there are a lot of people, we're seeing this renaissance of like, you know what? Like, there are some components of just healthy living, eating good food, not having toxicity in the stuff you put in your body, taking care of yourself, being mindful, getting some exercise, getting your feet on the ground, getting sunlight. We're seeing this resurgence of all these things that are just like part of normal life previously, which I think is really cool. So I think it really opens the door. A lot of people that we talk to that are in all sorts of different healthcare industries are looking for these things, are looking kind of like for the things that we are doing and saying like, I would love not to give a medication for this. Like, we get referrals from cardiologists and neurologists on a weekly basis. They're like, I don't want to have to give them this. I don't feel like it's working. Let's try what you're doing over there. The worst thing that could happen is we could spend time on it and nothing would occur. But what we find is like most people see a measure of improvement. Some people like a lot of improvement real fast. Some people work their tails off for it. All the way along, you can measure it and you can know if it's working. So it's never like, you're never spending like forever on it being like, I really hope this is going to work. You're like all the way along, you just keep testing things. And if they're getting better, then you just keep going. And if they get better, you keep going until you get to the point where you're like, I can do more life. So I think it's a really cool time to be in this seat and to just be lucky enough to be someone that got super interested in brains. And then that turned into brain rehab. And then that turns into like, oh, this thing that people thought was this other thing is actually kind of actually a brain thing. And to be able to just pull those things together, we're just like, it's just like the right time for it. So I get really excited, especially for questions like that, where I just think people have way more hunger to like try to solve things that way now than they did. And maybe, even when I first started, which not that long ago, but like kind of a little bit of a long time ago. So, yeah, anyway. So Mark said, thank you. Home to Colorado and Texas. Feels better at lower elevations. That's kind of the trend we tend to see, especially with people that have like vestibularly based onsets. So that may be a thing to think about, but that doesn't mean vestibular system alone. That just means the way we interpret kind of our position in gravity. So when we change barometric pressure, or like pressure from outside, that has effects on the way that we like control and feel the way that our head moves in space. So anyway, okay, so we'll hang for a minute. Anything? We've been out of 2 hours. It's pretty good. We got 90 people with us right now. That number's gone up and down throughout the time. I think it's really fun. I think we should keep doing it. Who should we bring in next time?
Oh, I think we have some patients that are just chomping at the bit, ready to get
know,
on here and share their experience.
Well, maybe those of you that are in the chat could let us know if that would be something that's interesting to you. And then also, like, we have tons of colleagues and friends and providers, both in our field from around the country and the world, but also other fields. Just kind of feeling this out because we want to provide some value from different perspectives as well. And then that way, kind of just be a source for information. We really just want to be able to let people ask better questions about themselves. And then I think that will lead to better outcomes regardless of who's the person that helps them. So, so whatever degree that works, we're going to be back next week. Our streaming, what do you think? Way better this time around?
Yeah.
I feel fancy now.
Really this good. Worked well.
Okay, cool. Well, again, I appreciate those of you that hung out. Again, please keep bringing your questions. We'll try to, if we don't do a good job answering them, just try to ask it again, but like with different words. And we'll try to see if we can close it down better. In some ways, we might have to just expand and it's hard to answer questions quickly. So sometimes it's beneficial if we could maybe teach a concept and then ask a question too. So we might have to think about doing it like that.
I think too, I know you touched on it last week, but there were a couple of comments just about provider referrals and if we knew someone in an area. So if that's specific to you, go ahead and send an email and we will do our best to try to, if we can, connect you with someone.
Sure. Yeah, it goes without saying. Yeah, we really appreciate it. Corey, good to see you. Mary, thank you for being here. Amanda, all the way through. Mark, great questions. Hope you're feeling better. I don't know if you're in. Where's better right now, you think? You think Texas or Colorado? What do you think? Dr. Kipros is a skier, so I'm thinking Colorado.
All right. Well, look like Dr. Keiser jumped off the Texas, Corey says. But thanks again for everyone who tuned in, and we're going to try to make this a weekly thing. So thanks to everyone who tuned in, and we'll see you again next week.